Hi everyone, Bedside ultrasound is an important clinical decision-making tool which every neurocritical care resident should know. In this video, we are going to see 5 bedside ultrasound scan from head to toe in 5 minutes, which is going to include optic nerve sheath diameter, IVC, lung, checking for DVT, bladder and echo. Let's begin with proper hand hygiene. Ensure patient's privacy. If patient is fully awake, make sure you get at least verbal consent before you perform the ultrasound. Then select appropriate probe. I use linear probe for checking optic nerve sheath diameter, lung sliding, DVT scan, and I used either curvilinear or phased array probe for checking IVC, diaphragm, effusion or bladder. Optic nerve sheath diameter. Place the patient in supine position and place the linear ultrasound probe after applying some gel transversely over the closed upper eyelid of the patient. You will get an image like this. This is the globe and you have to measure 3 mm from the globe towards the optic nerve sheath and measure the diameter. If the diameter is more than 6 mm, it indicates raise in ICP. Lung sliding. Place the patient in supine position. Place the linear probe vertically over the second intercostal space over the mid-clavicular line. So you will be able to see the parietal pleura and visceral pleura sliding over each other. It is called as shimmering sign. This can be better appreciated if you place M mode over it. If you place M mode, you will be seeing seashore-like appearance called as seashore sign. In case there is no lung sliding, that is, if patient is having pneumothorax, you will be seeing a barcode sign. In lung, we will also be seeing multiple horizontal lines which are called as A lines. It is in normal lungs. Whereas sometimes we can see vertical lines arising from the pleura till the end. So these comet tail artifacts are called as B lines. Presence of more than 3 B lines signifies either pulmonary edema or pneumonia. Then the PLAPS point. PLAPS stands for posterolateral alveolar pleural syndrome. This point is we go along the lower lung point along the posterior axillary line, and over this point we will be able to visualize our diaphragm, lung or any effusion if present best in semi-recumbent position. Over here we are able to see some anechoic structure which represents our pleural effusion. And if you see the lung, it is in the consistency of liver. We call it as hepatization of the lung. In this lung over here, we are able to see multiple white structures with some artifacts. So it is called as air bronchogram. Air bronchogram presence indicates consolidation. Next is IVC assessment. Place the curvilinear probe just below the xiphoid process and slightly tilt towards the liver. You will be able to see the IVC draining into the right atrium. From the IVC right atrium junction, 2 to 3 cm, you can measure the diameter of IVC both during inspiration and expiration. You can also see whether the vein is collapsing during inspiration. If it is more than 50% collapsible, then the patient is hypovolemic and he might be fluid responsive. We can also use M mode to measure the same. We can measure the maximum diameter and the minimum diameter during inspiration and expiration. Based on these values, we can calculate collapsibility index for spontaneously breathing patients and distensibility index for mechanically ventilated patients. This is the formula, and based on these values, we will know whether the patient can be fluid responsive or not. At times we tend to get confused whether it is IVC or aorta. IVC usually drains into the right atrium and hepatic vein drains into it. And also if you put a pulse wave Doppler over IVC, it shows continuous Doppler pattern, whereas if you place it over aorta, it will show nicely pulsatile pattern. Next is DVT scan. Place the linear probe transversely over the femoral crease. Once you find the artery and vein, try to compress the vein. Usually, if vein is compressible, it suggests there is no DVT. Trace the femoral vein downwards towards saphenous and popliteal vein as shown in the image here. Next is an important scan which most of us tend to miss when patient is having oliguria. So when patient is having reduced urine output and provided he is catheterized, make sure you just do this bladder scan. For that, you place the curvilinear probe just above the pubic bone and tilt it towards the bladder. So if you see inflated Foley's bulb with a fully distended bladder, you should always suspect obstructed Foley's catheter. Either flush the catheter or change the catheter so that the bladder drains properly. Last is the apical 4-chamber view. We keep the echo probe in the left fifth intercostal space, and slightly on tilting the probe, apart from the 4-chamber view, we can also be able to see the aorta. So in this view, we can check all the 4 chambers, check for contractility, whether RA-RV dilatation is present or any clots are present. Just around the heart, you can check if any pericardial effusion is present. Then in the second intercostal space, if the pointer is mediated towards the opposite shoulder, it is called as Plaque's view or parasternal long axis view. If the pointer is mediated towards the same shoulder, then it is called as parasternal short axis view. In these views, we can check for contractility and any hypertrophy. Last, make sure to wipe your probe and wipe your patient. I hope this video provided some insight regarding head-to-toe bedside ultrasound examination, which is very essential in all critical care setup. Thank you.